student, before you join the medical school, you are required to do medical checkup. So that medical checkup also include ECG. And for those who present to you after age 40, usually we will also do a baseline ECG. All right. So we covered what is ECG, who and when we will order ECG, and then where is the electrical rhythm. Then now we go to why we need to do ECG, why certain morphology is different in certain conditions, and then how to interpret ECG. Is the sound okay?
Yeah, all good.
Okay. So this chart will share with you in a glance each component, what is meant by P. Okay, so the first deflection is P, followed by PR interval. Okay, PR interval, the definition. So now we go to terminology. Okay, what is the meaning behind each segment? This is very important. Okay, you have P wave followed by PR segment, but PR interval stands for the interval taken from the beginning of P up to the beginning of QRS. Okay? So now we go to QRS complex. QRS complex is like that. If you take the top as positive, then below the baseline will be negative. Okay? Sometimes in EEG, we actually, the up one is negative. So ECG and EEG, even though both also electrical rhythm, one is electrical rhythm of the heart, one is the electrical rhythm of the brain. All right. And QRS complex, okay. Then you have ST segment followed by T wave. Okay. So now we are going to talk about what is P wave. P wave is depolarization of the atrium. Okay. QRS complex is the depolarization of the ventricle. T wave is the repolarization of the ventricle. So with that in mind, we are going to talk about standard calibration. Okay. This is also very important because when you interpret the ECG, if the ECG is done without the standard calibration, you may misinterpret the rhythm as too small, too fast, or the complex will become too small if, let's say, your calibration is under calibration. All right. So standard calibration is 1 centimeter represent 1 millivolt. Then the paper speed is 25 millimeter per second. Okay, 25 millimeter per second. Okay, right. So now we are going to talk about what are the normal rhythm followed by what are the abnormal rhythm. So normal, in the sense, it has to be normal heart rate. Okay, so the first step is heart rate. So when we talk about abnormal and then normal heart rate plus normal morphology. So abnormal ECG, you can further categorize it into 2 ways. You can classify them. One is based on each waveform. Okay, P wave abnormalities, PR interval prolonged, QRS prolonged, ST segment either depression or elevation, and then the T wave either very tall tented or there is a presence of U wave. So this one is based on the morphology of the PQRST. Okay. Another way of classifying this is you use 4 ways. Number 1 is the heart rate. Heart rate less than 60, that will be bradycardia. Heart rate more than 100, then it will be tachycardia. Okay, then whether is it regular or irregular. So if it is regular but heart rate is less than 60, then it will be sinus bradycardia. If the heart rate is more than 100 and it is regular, then it will be sinus tachycardia. Okay, so the first step is about heart rate. The second step is whether regular or irregular. And then you have this irregular rhythm, like your AF. But AF, I group them under the first step is rate, followed by regular or not regular. Then the third step is whether it originates from the SA node. So like AF, atrial fibrillation, it originates, the P wave is like the atrium is fibrillating, okay? They didn't contract in a very synchronized manner. So that one is atrial fibrillation, okay? And then you have something originate from the atrium, but there is it is not conducted in the normal pathway. Then you get these atrial ectopics, ventricular ectopics, something that not conduct in the normal pathway. So normal pathway start from SA node, AV node, then bundle of His, left and right bundle branch, okay? So now we are going to, the last one will be, it is the just now we mentioned regular, heart rate regularity, and then not originate from the SA node. Then you have also other example like junctional rhythm, the not conducted via the normal pathway can be ectopics, can be your Wolff-Parkinson-White syndrome, AVNRT, all those the abnormal rhythm. So we will start with this P wave abnormality, called P, that one it occurs in cor pulmonale, pulmonary hypertension. Bifid P occurs in mitral valve disease. This is also very important because sometimes you will get a short case, patient has mitral valve disease, mixed mitral valve disease or mitral incompetence or mitral stenosis. So when you talk about, I would like to do ECG, what do you look for? You want to look for bifid P wave. Bifid P wave happen when there is right atrial enlargement. Okay. P pulmonale happen when there is cor pulmonale, pulmonary hypertension due to underlying COAD or due to underlying right, left. Okay. It started with like valvular, the septal defect like ASD, VSD. Then after that, long-standing ASD, VSD with left to right shunt. Then there is pulmonary hypertension. Then later it can go to Usher-Mengel complex, the reversal of the shunt. So the moment the patient develop pulmonary hypertension, then you can have this P, tall and peak P. Okay, so irregular rhythm, you further divide them, narrow complex and broad complex. So narrow complex is your atrial fibrillation, sinus arrhythmia. Okay, what is meant by sinus arrhythmia? Sinus arrhythmia happen when young patient, during inspiration and expiration, they show significant heart rate variation. But it is within normal limits, okay? It can happen in young children and young adult. Okay, so you have sinus rhythm with PAC, and then atrial flutter with variable conduction and multifocal atrial tachycardia. The broad complex, if there is atrial fibrillation plus aberrancy, that means abnormal conduction, polymorphic VT, ventricular tachycardia polymorphic. VT can be regular, VT can be also irregular. The irregular one is the Tosa de Port. The pronunciation is called Tosa de Port. Even though the spelling is POINTE, the same like the absence seizure is like absence, but the pronunciation is French word, so that one is absence. So QRS complex, few pathological Q wave can happen in OMI, and then Q3 can happen in patient with acute pulmonary embolism. So in pulmonary embolism, you will have S1, Q3, T3. So what is meant by S1? S1 means there is a S wave in lead 1. Q3 means there is a Q wave, pathological Q wave, big Q in lead 3. T3 means there is a T inversion in lead 3. Okay, that one is the characteristic features of pulmonary embolism. So broad QRS complex can happen in IVCD. Later, I will show you the example. Okay, broad QRS, you also have LBBB and RBBB. So LBBB is the M pattern in V6, whereas RBBB is M pattern in V1. Later, I show you the example. So ST segment abnormality, ST elevation in acute MI, so then you further see where is the location of the ST elevation, whether is it in the inferior leads like 2-3 AVF, or is it in the septal leads V3, V4, or is it in the lateral leads V5, V6. Okay, ST elevation also can happen in pericarditis and Brugada syndrome. ST depression can happen in myocardial ischemia. Okay, and then reciprocal changes. Okay, if let's say there is some MI changes, then the opposite lead will show the ST depression. Tall tended T is the important cause is hyperkalemia. T inversion can happen in left ventricular hypertrophy with strain pattern. So when do you say this is LVH? You say this is LVH when V1 plus V5 or V6 is more than 7 big squares. Later I show you the ECG quiz. If some of you can answer, that would be very great. Because this is going to be a revision, right? So I give you all the salient points that has practical clinical significance. So the deep and symmetrical T inversion can happen in the non-Q wave MI. T inversion can happen in LVH with strain, Takotsubo cardiomyopathy, and sometimes CNS pathology like stroke, intracranial bleed also can produce T inversion. Massive pulmonary embolism, you will have T inversion in lead 3, Q3, okay? Okay, so now I show you the second one, the example. Can you see? Can, right? Can see it? Okay, so this is the example of sinus bradycardia. So normally we said you take 300 and then divide by the big square in the RR interval. This is the R. Okay, the N is that one is the R. So now I make it interactive. You can answer. Okay. I label the thing already, but okay, so this is sinus tachycardia. What is the heart rate? Come. Who wants to answer? How do I access to? How do I access your participant? Come. How do I see? Okay. Muhammad Bishido. What is the heart rate? Want to try? Anyone want to try? Come, volunteer. Let's make it as interactive as possible. So you use 300 divide by 2 big square. So it will be 150. So this is sinus tachycardia with the heart rate of 150. So when it is 150, sometimes you need to make sure, are you dealing with atrial flutter with 2 to 1 block? Okay, so this one is sinus arrhythmia. During inspiration, the heart rate become faster. Okay, so this is another example. There is a bit of different in terms of RR interval. So how do you see is this is clearer, This one is clearer, This one is clearer. But P wave is all well seen. And the P wave morphology also same. Okay. So this one is ventricular ectopic. Okay. So the morphology is different and it is a broader complex. Okay, ventricular ectopic. And then ventricular ectopic, sometimes you further need to mention whether is it multifocal ventricular ectopic or not. Is it something different morphology? That means the focus from different place. So this one is second degree heart block, Morbitz type 1. Morbitz type 1 means the PR interval continue to gradually prolong until, you see, this PR interval, the beginning of the P to the beginning of the QRS, continue to increase, prolong until one P is not conducted by the QRS complex. So this one is type 1, Morbitz type 1, Weckibert type 1. Complete heart block, there is AV dissociation. That means atrium, their rhythm is there, atrium. How do I, is there a point? How do I show you pointer? Can you see the PP and then followed by QRS? Then you have P, QRS. Then you have another P. Okay? So this one is dissociation of the atrium and the ventricle. So this one is complete heart block. Okay, so now I show you another one. Okay, MI changes. Okay, so you have anterior MI. This is anterior MI. There's ST elevation in the V2, V3. And then poor RA progression. V5, V6, V4, V5, V6. V4 still, there is Q wave already. V3 also start to have Q wave. So this is anterior MI. Here you have this extensive anterior STEMI, ST elevation in V1 up to V6, V5 up to, up to V5. And then you have anterior inferior MI. 2-3 AVF, you see? Inferior one is 2-3 AVF. So you see 2-3 AVF, there is ST elevation. Then the V1, V2 also there is ST elevation. Is your, and posterolateral. Okay? Posterolateral. You have your AVL, lead 1, very marked ST elevation, lead 1 and AVL. So this one is the anterolateral. V5, V6 also. Not very marked. V5, V6 not very marked. But your 3 show very marked ST depression. Okay, anterior MI, this is V3, V4, ST elevation. Okay. Then now we go to pericarditis. Okay. Pericarditis, they also got ST elevation, but the ST elevation, when you look at this, it is something like saddle shape. Saddle shape means, like when you sit on the horse. The horse, the back, there is a saddle, and it is something concave. So you see this ST segment is concave one. So this one is pericarditis. And what is the underlying cause for pericarditis? Sometimes it can be uremia. Patient with renal impairment, or it can be post-vaccine, COVID vaccine, then develop pericarditis. So it's important to diagnose pericarditis. Patient suddenly develop heart failure, and then you do the ECG, there is saddle shape of ST elevation. Okay, it can mimic MI, but the MI usually their ST elevation is not concave one. Okay, so now I share with you the quiz. Okay. Can I ask Hui Jin to interpret? Is Hui Jin here? So this is a 53 years old man. First, you talk about what is the heart rate, and then what is the abnormality noted before you go to the diagnosis. Is Hui Jin here?
Hello, doctor.
Yes, you're here. Okay,
come. Okay, good.
Wait, I try to close other thing. Okay. So can you see well?
I'll say the heart rate about 75 because there's 4 big box.
More than 4, right? 5. Almost 5.
4, yeah, 4.5 or 5 like that.
300 divided by 5. So what
60.
you get? 60, around 60. Okay, maybe more than 60 or 60, around that. So it's about like borderline Brady already, correct?
Yeah.
Okay. Any other abnormalities seen?
I can see
so
the
calibration is correct.
T-wave inversion.
Okay, good.
Some ST elevation over the ABR. That V1, V2. Yeah.
Okay.
And not sure, but the QRS complex from V1 to 6 is more towards the 4, 5, 6. So
okay, so now we use this case as how we interpret the ECG systematically. First is the heart rate. Okay, the second one is regular, correct? Heart rate is maybe around 60, so maybe it's in the bradycardia, and then it's regular. Then after that, you look systematically. So usually what I do is, first I look at general, any LVH. Is that LVH? So V1, V2 plus or V5, V6. Almost right. Can be right, correct? V5 or V6. Because when you see carefully, this calibration is correct. Calibration, standard calibration. Almost 7 square if you take V2 plus the V5 or V6. Correct? 2?
Yeah.
7. Okay, so there is LVH. And then there is ST depression in 1, lead 1. So you group them, 1 AVL. AVL you see or not? Yes, AVL also got T inversion. 1 also the T inversion, and then V5, V6. V3 up to V6. Okay, so this one is antero, septal, and lateral. Then you look at 2, 3 AVF. Group them, the inferior leads. Inferior leads also show some ST depression and T inversion. Okay, just now we mentioned ST depression means ischemia. Okay, and then LVH with strain pattern, there is LVH with strain pattern. All right. Okay, so there is ischemia in Anterolateral septal also plus the inferior. Okay. Okay, this is a very interesting ECG from a cardiologist. Okay, so it mentioned there. Okay, okay, multiple abnormalities. Okay, so V1 and V2 look at the right ventricle. One of you can read out.
Doctor, I will read out.
Mm.
So V1 and V2 look at the right ventricle, while AVL 1, V5, V6 look at the left ventricle. Right and left ventricular hypertrophy can be shown up with changes in this lead. Classical diagnostic criteria for right ventricular hypertrophy are right axis deviation of positive 110 degree or more, dominant R wave in V1 more than 7 mm tall, or R to S ratio of more than 1. Dominant S wave in V5 or V6 more than 7 mm deep, or R to R wave to S wave ratio of less than 1, with QRS duration of less than 120 milliseconds, which is the changes not due to right bundle branch block. The most commonly used voltage criteria for left ventricular hypertrophy is the Sokolov-Lyon criteria. S wave depth in V1 plus torus R wave height in V5 to V6, which is more than 35 millimeter. Voltage criteria must be accompanied by non-voltage criteria to be considered diagnostic of left ventricular hypertrophy, which are increased R wave peak time more than 15 milliseconds in leads V5 or V6, and ST segment depression with D wave inversion in left-sided leads. Left ventricular strain pattern. Yeah.
Okay.
So
Okay.
yeah,
Thank you.
Okay.
You can read the next one.
Oh, okay. So ST elevation in V1 to V3 brings to mind ischemic heart disease with septal myocardial infarction. However, clinical features of MI should be present with elevation of cardiac enzymes, which is troponins, and serial evolutions of ECG changes. The ECG in MI will tends to have reciprocal changes in the leads opposite to the site of MI. In this case, the ST depression are widespread and not in the leads opposite to the site of ST elevation. Pericarditis is another condition producing ST elevation, but the typical pattern is concave upward ST elevation in contrast to the convex upward ST elevation in MI. Yeah. So,
Okay.
yeah. So for examination purpose, if pressed about differential diagnosis, cause of T wave inversion can include hypokalemia and intracranial lesion, and the diagnosis of hypertrophic cardiomyopathy is confirmed with a prior ECG being exactly similar to the present one.
So this case is actually having hypertrophic cardiomyopathy, and then because of the hypertrophy, there is also ischemia. Okay. It's interesting, but it's not the MI. Okay, so now I let you see again the ECG. There is ST elevation in V1, V2, correct? But the pattern a bit like got some bundle branch block, but it is not a complete bundle branch block, because the complete bundle branch block, you will see the M pattern in V1 and then the W pattern for right bundle branch block, and then left bundle branch block, you will see the clear M pattern in V6. So maybe later I show you another case. So let me show other ECG. Okay, so this is the one. Okay, horizontal you can see clearer, right? Okay. So
Yes,
posterior infarct, you have this additional leads V8, V9, V10. And your interest is to see any ST elevation. So like you see, this V7, V8, there is ST elevation. So that means the standard ECG, we only do the up to the V6, right? But we also added the posterior part to look at the posterior ventricle, added the leads V7, V8, V9. That one is posterior chest wall. Okay. So just now we covered 5W1H. This 1H also include not only how to interpret, how to do ECG. Where do you place the leads? So I let you revise where do you place the leads. For the V4 is in the mid clavicular line. So you take the clavicle, then V4, anterior, mid clavicular. V5 is in the anterior axillary line. And then the V6 is the mid axillary line. Okay. Okay. So now we go to this. How come this is only one page? Oh, okay. Okay. We are now in already half an hour. So okay, start with this. So this one is normal, normal ECG. Can you see? Very regular. Okay, maybe got a bit of T inversion in lead 3. Lead 3. Okay, got a bit of T inversion in lead 2 and lead 3 actually. The long V. Okay. So this is the sinus arrhythmia. Okay. P wave is well seen and is the same morphology. PR interval also same. Okay. Then this is bradycardia. So many big square. Okay. So heart rate is how? What is the heart rate? Brady, you want to try? What is the heart rate? Is Brady here? Is Brady here? Or Wang Hui?
Yes.
Come. What is the heart rate?
Okay, see back.
Can, sure. 300 divided by
7.
7.5 lah, around 7 and around 7 like that lah. Okay, can. So 300 divided by 7 is how much? Definitely Brady lah, correct?
Oh yeah.
Less than 50 also, right?
Yeah.
The heart rate is less than 50, 40 plus only. So that is sinus bradycardia. So this one is sinus tachycardia. But I mentioned if let's say the heart rate is 151, you must make sure you are not dealing with atrial flutter with 2-to-1 block. Okay, so you need to slow the rhythm and see whether got flutter wave or not. And how you can slow down you can do the carotid sinus massage to stimulate the vagus nerve stimulation. So this one is ventricular ectopic, broad complex. Okay. Okay. So this one irregular, correct? Irregularly. Okay. So now you see some P wave, but not conducted by QRS. So now the question is, there is also some T inversion, ST depression. So causes of ST depression also include your, digoxin toxicity, the reverse tick sign. So we need to make sure, is the patient taking any digoxin or not? For this case, it is AV association, the AV dissociation with a reverse tick sign. And then when you do the TDM level, therapeutic drug monitoring of the digoxin, it is very high. Patient is having digoxin toxicity. So patient actually has digoxin toxicity with the reverse tick sign. The ST like a tick, but it's a reverse one. Okay, so now you go to this. So patient has prolonged PR interval. This one not very clear. Okay. This one not very clear. This one not good. This one not good example. So we skip it. Okay, so this one. Also very bready, correct? And then is it regular? Is there any AV dissociation? Looks like got AV dissociation, right? So this one is complete heart block. So when it is bready, the next step is whether there is any AV dissociation. Because most of the complete heart block patient, their heart rate is slow one. And causes of complete heart block include sick sinus syndrome. Sometimes they need pacing, they need pace. And depending on what is the underlying cause, inferior MI also can cause bradycardia, and it also can cause heart block because inferior MI, it will affect the conduction fiber. Okay, so this one. This one. Who wants to try? Priscilla? Can you try? What do you see? Priscilla here, right? Okay. Can I show the thing? Okay. First is always heart rate. What is heart rate?
Heart rate.
300 divided by 4.
Yeah. 300.
So, what's the heart rate?
75.
70 something. So within normal, okay? And then it's quite regular. Is
Yeah.
P wave seen? P wave is seen? Yes, P wave is seen.
Yeah.
Okay. Yes, P wave is seen. Okay, what's the abnormality seen now?
The abnormality.
So standard calibration, correct, right? 25 millimeter per second, and then the 10 millimeter per millivolt. 1 centimeter per millivolt. Okay. ST elevation, V2 and V3.
Okay.
V4 also, V4 also got a bit. V5 also got a bit. Okay, for limb leads, for chest lead is 2 millimeter at least. For inferior leads like 2-3 AVF, that one is called limb. That one is called limb leads. That one 1 millimeter, one small square already significant. So what is this? This is another one. Okay, this is another one. You see now, the whole V4, V5, there is poor RA progression already. Maybe different timing. Is it the same patient? 72. This one heart rate 75. Becomes slower already. Okay. PR interval is a bit borderline. Yeah, because we usually, this is almost like 1 square already, the PR interval. 1 big square already. So now you see inferior leads got ST elevation 1 millimeter. The first one not so clear. Maybe got a little bit, but not so clear. But that's why we need to repeat ECG. If a patient present to you with chest pain, or they present to you with shock, BP is very low, sweaty. Some diabetic patient, they can have silent MI. they don't have ischemia because they can have neuropathy. So they don't feel, they have the ischemia, but they don't have the chest pain. So this one, you repeat, now you see very clear ST elevation in lead 1, lead AVL, V2, V3, V4, and then ST elevation in 2, lead 2. So AVL didn't see clearly. Okay. So this is another ECG. Okay, this is anterior MI, this is anterior infarct. Anterior leads, poor RA progression, V3, V4, all totally, because now infarcted already, okay, this is broad complex. Okay, broad complex. Okay, this one interesting. Who wants to try? I call name, Wee Chong. Oh.
Hi, doctor.
Mac. Okay.
All right, so patient has a heart rate of around, so there are 3 big boxes, around 100 beats per minute. The rhythm is regular for me.
Good.
Okay, and there's broad QRX complexes. So I think patient is having a ventricular tachycardia.
The V5, V6, V7 look like that. I mean V4, V5, V6 look like broad complex. But when you carefully look at V1 to V3, the complex is actually narrow one. The QRS complex is narrow. It looks like got ST elevation in V2, V3. Correct? AVF also, and then 2, 3 AVF. And already, if you look carefully, P wave not very well seen. Right? Some of the, but in here looks like got in V2, V3, V4 got P wave. Correct? There is a P wave with the PR interval. So this is something you may not be expected to know how to interpret because it's not so straightforward. But this patient actually has an extensive anterior MI. So subsequent ECG, okay. So first one you cannot see where got ST elevation. But this ST elevation, isn't it look like saddle also? Correct or not? Like concave one, right? So when you repeat now, different already. You see V3 is still concave, right? When you repeat, now V3 become broad already. So maybe it started with the lateral, then after that septal also become blocked. Now you see clearly, lead 1 is already ST elevation. Right? 2 also ST elevation. AVF also ST elevation. It's more than just anterior. It's very extensive. Inferior also start to be involved already. The AVF and 2 is also involved. Okay, so I show you another one. Okay, basically tonight you can familiarize yourself with the ECG. I show you 2 more, then we call it a day, okay? This is also ST elevation. V2, V3 very marked, and then V4, V5, V6. And then poor RA progression. AVL also, lead 1 also. So these are anterior, extensive anterior. This is also extensive anterior. Okay. Okay, 2 more. I show you 2 more. Okay, how do I Okay. This is the same extensive anterior. This is also, this one tachycardia, heart rate more than 100 because less than three big square, and then it's regular, ST elevation, Q wave, marked Q wave already, no more. You see, it's very marked Q wave in V1, V2, V3. And then mark ST elevation in V5, V6. V5 only, V5. V4 also, ST elevation, V1, V2, V3, V4. So this is also MI, okay? This is also MI. So you need to give streptokinase. Okay. LBBB. So now I show you the LBBB. Okay, this one got a bit of LBBB changes, but it's still not the classical one. Okay, I show you the classical one. This one also MI changes. Okay, MI changes. It's anterolateral. Okay, extensive. This one also. This one is this one is not convex. This one is convex, not concave already. Mark ST elevation with reciprocal ST depression. So this is anterior. Lead 1 is anterior, and then AVL is it prolonged? AVL, yes. So lateral also, extensive anterior, anteroseptal. Lateral, okay. Lateral V5, V6, okay. So is anteroseptal, okay. V5, V6 involved, then you'll be lateral involvement. Inferior one is the 2-3 AVF, okay. 2-3 AVF, you see. Yes, 2, 3, 3, 2-3 AVF ST elevation with Q wave form already. So this is MI, inferior MI. But also got anterior because your V4, V5 also involved. But the 2-3 AVF I didn't include, is it? Also got inferior, Also got inferior MI. You want to see the LBBB? Wait, I find for you the LBBB. Oh, okay. Do I have it? Okay, this is the VT. This is the VT, This is the VT. All throughout you broad complex, and then regular and tachycardia. Wait, I show you the LBBB. Sorry, just now I think I opened up the wrong one for you. Yeah. Do I have the LBBB? So this is the better version with the description and the diagnosis. I don't have the BBB for you. Sorry, the next session I will show you, or I will put in the Telegram. I'm going back already. Okay, have a good day. Any question? Okay, let's sum up what did we learn today. Today we talk about what is ECG, electrical rhythm from the heart, and then it started from SA node, AV node, bundle of teeth, left and right bundle branch. Then each component, P wave represent atrial depolarization, QRS is ventricular depolarization, and T wave is the repolarization of the ventricle. Then we said you classify the abnormality based on each wave, P wave, either tall P or bifid P, and then prolonged PR interval in first degree heart block. Then you have or broaden QRS complex, and then ST elevation, ST depression, and T inversion. So each one of the component, you need to know what are the causes. Then we talk about, you can also classify based on heart rate, less than 60, more than 100, sinus or regular or not regular. Then we talk about whether it originate from the SA node, not originate from the SA, then you have your ectopics, you have your junctional rhythm, AVNRT, the Wolff-Parkinson-White syndrome, all those not conducted via the normal pathway. Then you have the typical MI changes based on the distribution of the ST elevation, where is it? Then you talk about whether is it inferior MI, 2-3 AVF, enteroceptor, then your LIP1 and AVL plus the V3, V4. The lateral one will be the V5, V6. Posterior one will be V6, V7 to 9. V7, V8, V9. Okay? Any question? If no, okay, thank you. Bye-bye.